I'd like to thank the organizing committee for inviting me for this talk, and uh, I'm going to be presenting the results of our ketamine versus ECT study, what's called the ELECT-D trial. And this was sponsored by the Patient-Centered Outcome Research Institute, which is working. It's not working.
I think there's a separate thing, isn't there, for the...
Huh?
Press the top button.
Top button, yeah.
Yeah, point it at the screen, hold it
Okay,
there.
hold it.
Hold it there and then you'll find it.
Okay, all right. Okay. So, okay. So this was sponsored by the Patient-Centered Outcome Research Institute, which basically does studies more from the patient's perspective. So I think that's important, and I will talk about that a bit later. I don't have any disclosures. There's no commercial disclosures except the grants for the study. And this was the paper we published last year in May 2023, which created a little bit of a effect all around, particularly on ECT practitioners. And so I'm going to be presenting the results of that briefly. However, I did want to talk a little bit about the context. Lots of people here have talked about the history and the context. And so there's a bit of history that I was part of, and which is the other big paper, which was published in 2000, known as the Berman paper, which was the first study of showing that ketamine has an antidepressant effect. So I can tell you now that at that time when the study was done, and even when the results were in and the paper was getting published, it was a fairly low-key affair, and nobody would have imagined that in about a decade or two, ketamine was going to be used all around the world, and that we'll be having a ketamine conference here dedicated to ketamine. And one of the reasons why it was a low-key affair was because we were not just trying to, we were trying many different strategies for rapid treatment of depression. The main question at that time, and I was a junior faculty at that time, the mandate was to find fast-acting antidepressants. We also tried another drug called Pindolol, which is a presynaptic 5-HT1A antagonist, which was thought to increase the effects of Prozac, make it more quicker. And the reason was that the SSRIs had come in the 1990s with a lot of expectation, and one of the expectations was that they will work very fast, which did not, didn't happen, and they were also not found to be as effective or nearly as effective as a TCA. So there was a bit of disappointment regarding new medications, and there was an urgent need to actually try to find something which can make the action of these medication faster. So under these circumstances, the ketamine study was done, which was, another group was doing studies on schizophrenia, and they found that it causes mood elevation. And so we said, well, why not try it for fast antidepressant action? So I mentioned that because I think over time, and even in this conference, I find it a bit confusing, but over time, so over time, this rapid treatment of depression, the focus on rapid treatment of depression has actually shifted more to treatment of resistant depression. All of us, many of us are talking about treatment of resistant depression much more than rapid treatment of depression. And this is thanks to STAR-D. In 2006 it was, and because since STAR-D, if you're writing a paper, you're writing a grant, trying to get IRB approval or a patent approval or whatever, all you have to write is STAR-D said 1/3 of patients don't respond, and then you can go on with whatever you want to do. And also, Zarate's paper was on treatment-resistant depression. However, the problem with that is that there's no clear definition of treatment-resistant depression, And it's all, in my view, it's a heterogeneous population which may have many different causes of depression. For all I know, it may be a neurodegenerative disorder. And it may not be responsive to many treatments. And actually, pharmaceutical companies for a long time would actually exclude people with resistant depression as part of the testing of their drug. And it also can happen that people may be equally, these TRD patients may be responsive to many different medications in the same way. So they may be equally responsive to all treatments. However, for some reason, this has persisted and has become the main focus of attention, while the rapid treatment of depression, even though it's a clear-cut condition and it's life-saving, so we talked about suicidal depression, it's a life-saving treatment if you can actually rapidly treat somebody's suicidal depression, but less sort of emphasis is given on that. It is also difficult to get approval for, I think, and also difficult to do these studies. So it is not being done, and also it's not a good business proposition for particularly a pharmaceutical company which actually wants to give it to as many people as possible and for as long as possible. So just a very clear circumscribed sort of time period is not good enough. And I put the FDA label indication for ECT, and it is, as you can see, it says anybody who requires a rapid response due to the severity of their psychiatric or medical condition, and then sort of mentions in passing, or who are treatment resistant. So ECT has been around for 80 years, and it has mainly been around for rapid treatment, in my view, rapid treatment of depression, actually decreasing people's suffering quickly, and it is very effective in doing that, or thought to be effective in doing that. And the other part which I put in here is that there's a bit of a gap between the clinician's perspective and the patient's perspective about ECT. Clinicians have been giving for 8 years, they don't have any problem giving it, but patients don't like it. There's social stigma, there's significant memory loss, and there's side effects of general anesthesia. But the reason why ECT has survived for 80 years is because we didn't have any alternative for ECT. There was nothing else which could actually get people better so quickly. Until, of course, ketamine has come about, and here it's a dramatically different kind of a treatment compared to ECT, as you can see, and as you know. So the patients, it's actually the other way around now. It had become the other way around, that the patients actually liked it and wanted it, while the clinicians actually were a little bit reluctant to give it because they were concerned about its addiction potential and maybe some of the side effects. So in 2016, which is hard to believe, 8 years back, ketamine clinics were like popping up everywhere in the US. And it was not covered by the insurance company. People were paying anywhere from $1,000 to $1,500 per infusion. And it was really a big thing at that time. So it became imperative for us to, compare ECT with ketamine. And that's where the study of ECT versus ketamine was born. And as there was a gap between the patient perspective and the clinician's perspective, and that's what PCORI, or the Patient-Centered Outcome Research Institute, is looking for, was looking for a situation in which there's a gap between the two perspectives. That's why we applied for funding there and did this study. So this is a very different kind of a study compared to the more rigorous or so-called rigorous sort of usual kind of studies. This is what is called pragmatic trial. So this is an open-label pragmatic trial, and by that we mean is that we wanted to mimic day-to-day clinical treatment rather than actually put a lot of constraints on the trial in terms of the scientific aspects. It was a randomized trial, though, so patients who were coming in were randomized either to ECT or ketamine in a parallel manner, and it was statistically the statistical design was non-inferiority, which is that because ketamine was so easy to use, patients liked it. So even if it was 90% as effective as ECT, we powered this study for, then we thought it would be a positive trial. And even so, for these kind of comparative effectiveness trials, you need a large number of subjects. So our N was 400 subjects, 200 in the ketamine arm, 200 in the ECT arm. So this is the design of the trial. So TRD patients or patients who were referred to ECT treatment by the providers, they were the ones we actually approached for the study. In ECT services around at various sites. We had 5 sites, and at each site there was a ketamine expert and an ECT expert, and patients who were coming for ECT treatment, they were approached, and if they gave consent, they were randomized to either ECT treatment 3 times a week for 3 weeks, or ketamine 2 times a week for 2 weeks. And then the people who responded were followed up for 6 months, what we call naturalistically, that whatever treatment they were supposed to get, they would get. And we had time points at 1 month, 3 months, and 6 months. In keeping with the pragmatic trial sort of philosophy, the inclusion-exclusion criteria were minimum. Main thing was that they had to be referred by their provider for ECT, and they were like moderately depressed, and they had to have at least 2 adequate trials in their lifetime. That's the definition that we chose. And this was mainly an MDD study, so no bipolar patients and no psychotic patients, and of course any other contraindication like psychosis. The interventions, as I said, were ECT, which was right unilateral starting off, ultra brief pulse, 6 times seizure threshold titration, and intravenous ketamine was a standard 0.5 milligram per kilogram. Now these were, in terms of a pragmatic trial, these were not how these interventions had to be given. These were recommendations to the clinicians. They had full flexibility in giving ECT in any way they wanted and ketamine in any way they wanted. So if they wanted to change to bilateral, they could change it. If they wanted to give more ketamine, they could do it depending on the patient response. So it was a flexible trial. Most of the nearly all patients were started with this, and there were some changes made with some of the patients. And another unique aspect of this study was that we did 3 types of outcomes: patient-rated, rater-rated, and clinician-rated outcomes. And we had a firewall in between these 3 outcomes. So for example, the rater didn't know what the patient ratings were, and the clinician didn't know what the rater or the patient ratings were before they did their own rating. The primary outcome measure, keeping in mind PCORI's mandate, was a self-report measure, the QIDS SR, and the main response criteria was 50% decrease at the end of treatment in the QIDS SR score. There was various secondary outcomes, and we also did a cognitive battery, which has not been done in other studies at the beginning and at the end and during follow-up. So these are selected baseline characteristics of the population: 200 in the ECT arm, ketamine initially, who went into the randomized into the study, and 200 in the ketamine arm. And I think if you see it, it was mainly a middle-aged population, mainly white population, because that's the population that gets ECT in the US mostly. And importantly, only 10% of the patients were inpatient. Most of these patients got ECT as outpatient. And they had multiple episodes, a very long duration of the current episode, about 24 months as a mean, and they were moderate to severely depressed. And these are the results of the study, which hopefully you have seen, but what we found was ketamine was definitely non-inferior to ECT. In fact, as somebody said, it actually was superior to ECT, but because our original hypothesis was non-inferiority, we can only say that it was non-inferior to ECT. So the response rate with ketamine was 55%, and with ECT was 40%. And this is what is called the modified ITT analysis of all the patients who completed at least one one treatment and one post-treatment assessment. And we found this thing in both the patient rated the QIDS-SR score as well as the MADRS score. I don't know, this seems to be working. Okay. All right. So in terms of key secondary effectiveness outcome, this is, again, we couldn't talk about it that much because the New England Journal of Medicine doesn't allow you to talk about anything except what we originally hypothesized. But what you can see is there were abysmal remission rates for both ECT and ketamine. So 20% remission rate for ECT and 32% for ketamine. And for cognitive endpoints, we did see that a significant memory problem with ECT compared to ketamine. And the top two are the GSE, the Global Self-Evaluation of Memory, and the SMCQ are patient-rated, and the lower one is the Hopkins Verbal Learning Test, which is actually somebody doing the cognitive testing of memory. And all of them showed that ECT caused significant memory problems within 3 weeks of treatment. So just going, so just to reiterate, I mean, the response and the remission rates were very poor, and there were significant memory problems with ECT. And in terms of adverse event, we didn't really see very much, fortunately. Ketamine did cause more dissociation, which was expected, and ECT did cause musculoskeletal pain and weakness and memory disturbance. We didn't have any suicides. There were 1 or 2 suicide attempts, which was expected. And we didn't have, from what I know, none of these site PIs told me that anybody got addicted to ketamine while, after doing this treatment. In the follow-up phase, we followed people up, and as you can see, most people actually many patients continued their randomized treatment in the follow-up because they could get any treatment that they wanted. However, there was a very significant relapse rate over time. Within 6 months, 56% of the patients who got ECT relapsed, while 34% of the patients with ketamine relapsed. So if the remission rate is already about 20 to 30%, half of those people relapse, both of these treatments don't seem to be very effective. So in terms of limitations, we had several limitations of this study. There's an open label design. We did not stratify by age. We did not investigate bipolar depression. And this was mainly an outpatient, and I'll emphasize that more outpatient ECT population. We have been criticized that we did not give enough ECT. We should have given more ECT. However, I'm sure the response rate would have been better if we had given more. I think it would have unlikely to have changed the non-inferiority finding, but it would have definitely increased memory problems. Patients would have reported much more memory problems if more ECT or more powerful forms of ECT would have been given. So just about the time that we published our paper, there was actually a group from Sweden who beat us to it and published their findings of a comparative effectiveness trial and found that ketamine was inferior to ECT with 71% response with ECT and 57% response with ketamine. And there were 2 large meta-analyses which were mainly driven by the Swedish study. All the other studies in that analysis were very small, so it was not a surprise that they actually replicated the finding of the Swedish study. However, all 3 papers do say that yes, ketamine was inferior. However, the difference was small, and considering ketamine's ease of use and acceptability by the patients, ketamine should be definitely considered in these patients. And here I have basically I'm reviewed the differences between the Swedish study. They have actually published a paper on that, but it was a very different study. This was in inpatients. The Swedish study was in inpatients. They were all of them were inpatients, and they were a very short period of depression, and they had bilateral ECT, and the ECT was given as brief pulse, and even they even included psychotic patients, which psychosis has been noted as one of the factors which increases ECT response. And one thing I did notice that if in younger patients their response rate was not any different between ECT and ketamine. So the most of the response rate was driven by the older population, greater than 50 years of age. They also had a very high relapse rate within they had a 1 year follow-up, but within I think median of like 2 or 3 months, about 71% of patients on ketamine relapse and 63% of patients with on ECT relapse, a very high relapse rate. And we have also looked at predictors of ECT versus ketamine treatment, and the main thing we found is we didn't really find anything very predictive, except that if you're inpatient and if you have severe depression, then maybe ECT does have a higher response rate. So I think this was a large study, and maybe not as large as what industry does, but for sort of a research group, it was a large study that was done, and is the largest study ever done, both on ECT response as well as ketamine response. And I think we can safely, because of the large sample and the power of the study, we can actually derive some kind of conclusions from this. So for non-psychotic middle-aged treatment-resistant outpatients, ketamine is non-inferior, if not superior to ECT, both in its effectiveness as well as side effect profile. Therefore, my opinion would be that anybody who's going for ECT, particularly this particular group of ECT, who's going for ECT, should be offered ketamine treatment always. And however, because ketamine is still an investigative drug in the U.S., but IV ketamine is. It is actually, we have a problem. We cannot give it to patients because it is investigational, and it costs a patient out of pocket, as I said, about $1,000 to get a single IV infusion. While Spravato, which is 200 times more expensive than ketamine, a dose of ketamine costs $4 or $8, while Spravato costs $800. But it's cheaper for the patient to get Spravato because it's covered by insurance. So we have to really somehow get IV ketamine sort of covered through insurance. And even for inpatients with more severe depression, ECT may have an advantage. ECT may have an advantage, though the margin of advantage is small. So even for those patients, I think we should look at that. So finally, these are some of my other conclusions that future studies are needed to investigate the efficacy of these new agents, of new agents, and also of comparative effectiveness trials of ECT versus ketamine in acute settings, such as acute suicidality, because both of them are found to cause a rapid response. So we should really do that. But both treatments are not very good. I mean, they have like a 50% response rate, 40 to 50% response rate. So both treatments are not very good, and we need to develop better treatments. And as far as TRD is concerned, or treatment-resistant depression is concerned, we need to do more research on that because we have not solved the problem of long-term treatment-resistant depression. The only thing we have solved is that we can just keep on giving these medications, as was discussed with Spravato, just periodically to keep at least a subset of patients well. But we haven't found anything for TRD by actually discovering ketamine or esketamine. And TRD may not be the best population to investigate new ketamine-like drugs because there's much more likely that they will fail. And there was a recent I think Jerry was one of the authors for psilocybin. There was a trial in JAMA, which was done on depressed patients. It was not done in treatment-resistant depressed patients, and showed a very good response with psilocybin. So going back to our original study 20 years back or 25 years back, that's what we were trying to do. We were trying to find a new antidepressant which works quickly. We were not trying to find a cure for treatment-resistant depression. So that's something, hopefully, that's a message that I would like to convey, because I just feel that there's a lot of confusion. Even though people know this is a very simple fact, people know it, but I just feel that people keep on conflating the two different indications again and again. And walking the walk, walking the talk, sort of. We are actually not doing a very big trial, or we are planning to do a very big trial, even bigger than the one we've done now, of 1,500 patients with comparing ketamine and ECT for suicidal depression. And we have about 11 to 12 sites around the US and one in Canada. And we are looking for more sites, so if anybody's interested, let me know. We will even be looking for international sites if a contract can be done. So I will not be here to tell the results of this in 2 years, but in 6 years' time. And I'd like to finish thanking all my PIs who worked with me, and they did all the hard work. And it was actually a major achievement to do a 400 subject study in the middle of a pandemic and reach our end. Thank you.
Thanks very much for taking us through that lovely study. Probably got time for a couple of questions. Anyone? If I could ask you about patients who have depressive psychosis. Are they excluded at the moment from these kind of studies? They're the people we might use ECT for.
Yeah, well, that's an interesting question. Currently we are excluding them, and it was excluded in our study. In the Swedish study, they were not excluded. And there's more and more studies are coming out that actually ketamine may actually be safe to give with psychotic patients, psychotic depressed patients. We don't give it to, obviously, for schizophrenia patients or primary psychosis, but there are at least 7, 8 reports showing that doesn't seem to be. But it'd be difficult to get it through an IRB to actually give it ketamine to psychosis.
Yeah. First of all, I want to thank you for this study. I think this is clinical research at its best, answering real questions that have applicability in real world patients, not rarefied exclusion criteria that doesn't apply. So this is has immediate translatable benefits. I wonder what your thoughts were about the differences between this study and the Swedish study. My take, and looking at the Swedish study, was again, the design and the expectations. In the Swedish study, they were patients who actually had already consented for ECT, and then they were asked to participate in a study where they were randomized to get what they originally were prepared for, or this thing called ketamine that nobody, even including the investigators, really had any experience with. I mean, this was an ECT kind of oriented hospital. So I think the whole setup it was kind of set up for ketamine to fail in terms of prepping patients for it. They had no experience with ketamine. I think that's got to make a big difference. If you already have people who they're not randomized, they're taken from consenting for one thing and then told they may get something else.
Well, I mean, we have been criticized that most of the primary investigators are all ketamine researchers, but we did actually have a partner in each of the sites who was an ECT expert, and we had tried to keep the equipoise as much as possible.
Thank you, Amit, for an excellent study, and I concur with everything David said about real-world comparative effectiveness studies. I think are so important. We used to do kind of the typical, very stringent efficacy RCT, but our group is likewise moving much more towards these real-world comparative effectiveness. But just coming to that point about ECT versus ketamine, I know there's been a lot of angst, a lot has been written. I think both studies were excellently done, and to me, the results are entirely consistent. When you look at the ketamine response, it's almost identical between the two studies. The difference is the ECT response. When you look at the ECT parameters, the dosing was much higher, significantly higher. On average, 350 millicoulombs, yours is about 250. They gave brief pulse. When you look at the starting pulse width, it wasn't just ultra brief. And of course, your devices in the US are limited to 500 and roughly 500 millicoulombs, whereas most other countries in the world, it's 1,000. So the actual doses given in terms of total charge was also more. And to me, that probably explains the difference. I think you guys have given ECT well within the US context, where you're limited by that device restriction of the charge, etc., which other countries are not. I'm currently running an international multi-center ECT trial with sites in the US led by Mark George, Vaughan McCall, very experienced researchers and academics. And we have to develop a completely different dosing protocol for the US sites to accommodate that big difference in dosing, that you guys are allowed to have half the dose range compared to the rest of the world.
Oh.
When you look at the Sackheim studies, because people say, how come your remission is so low compared to the Sackheim studies? Harold Sackheim had a customized ECT device with a maximum charge of 1,500 millicoulombs, not the 500 for the standard clinical device that you guys are using. So these are a lot of the fine details that I think are often not known. But I see your results as entirely consistent with the X-strand results, given those differences in ECT practice, which are optimal for both countries.
Yeah. So just very quickly to answer that, I would say, one is, so we had, our response rate was 40% with ECT and 55% with ketamine. So for the non-inferiority result to change, the response rate for ECT would have had to be like more than 60%, okay, which I think was unlikely to happen, even with more ECT or more parameters. Now, the Swedish people didn't do the cognitive testing. We don't know what the cognitive testing would have looked like after that. And just very quickly about the inpatient part, I think we don't talk too much about the placebo effect of being inpatient. Amount and that ECT can be given much more aggressively when people are inpatient rather than outpatient. So just the fact that people are getting more response in inpatient could be due to, and patients also know they can't get out of the hospital until they get better. It is not even a joke, because that's true. We see it in suicidal depressed patients. They know they can't get out until they say they're not suicidal. So if somebody's getting ECT, they're depressed and all, they know they're not getting out until they start feeling better. So there could be many factors, but difficult to know. But your point is taken. Thanks.
Thanks very much.
Thank you.